It's a Northwest lifestyle weekend on Komo News. IRG's Health Talk continues.
First guest today is Dr. Nariman Heshmati, Medical Director of Obstetrics at Providence Regional Medical Center in Everett. Endometriosis. I've heard of it, but I don't know what it is.
We are going to learn about it, Tom. This is a women's health issue and a significant problem for a lot of women. And, you know, it's one of those things that, if addressed, can be diminished and controlled. And also, women's health physical therapy helps with this.
Okay, let's get to it. Dr. Nariman Heshmati from Providence Regional Medical Center in Everett, along with Shannon O'Kelly.
Dr. Heshmati, welcome.
Thank you.
How are you doing today?
I am doing well. Thanks for having me.
Well, thanks for joining us. March was National Endometriosis Month. I know we've passed March, but I'm glad you're here. We're going to talk about endometriosis. But before we do that, our listeners always like to find out about your practice, your training. Give us a little background, where you trained and what your role is at Providence right now.
So I'm a board-certified OBGYN, so that means we specialize in women's health. I did my residency at Vanderbilt University, and I am in private practice at the Everett Clinic, and I'm the medical director of obstetrics at Providence Regional Medical Center in Everett.
Great. Vanderbilt, I got to ask, country or rock and roll?
While we were there, you have to listen to country.
Yeah, absolutely.
But once you leave there, the country's gone.
Yeah, exactly.
And you lose your accent.
Now you're in Seattle, and it's grunge, right?
Now it's the Seattle grunge.
Yeah, exactly. So endometriosis, what is it, and who gets it? And tell us about that.
So endometriosis is really, really common. About 10% of reproductive age women have it. Endometriosis is basically when you've got the glands, that lining inside the uterus, and it's present outside the uterus. And it can be right outside the uterus, it can be on the ovaries, it can be as distant as the lungs. And, we take a look at that and we go, well, 10% of reproductive age women, but it's 40% of women who have infertility, and about 70% of women who have pelvic pain have endometriosis. And, what people start to notice when they have this is they're going to have a lot of pain leading up to their menstrual cycle. They're going to have significant pain during their menstrual cycle. They might have pain when they pee, pain with intercourse, so it can really affect quality of life, and it does result in infertility.
And what is it from a physiological standpoint? What's going on?
So what happens is those glands that are inside the uterus, they respond to hormones like estrogen. So they're going to grow, and then they're going to bleed when somebody has their menstrual cycle. Now imagine those exact same glands now outside the uterus where they're not supposed to be. So they respond to the same hormones, and they bleed. So you've got bleeding going on in the pelvis, and that's going to cause scar tissue and adhesions, and it's going to cause pain.
Wow, it sounds painful. It sounds very painful. What are the signs and symptoms? And then is there an age range? You talk about reproductive age, but what about younger women?
So, the average age of diagnosis of endometriosis is 30 to 40. But when people come in, typically they've had symptoms for a long, long time. So the classical person will come in and say, you know what, I had really painful periods, and my primary care doctor started me on birth control pills, and my periods got a little bit lighter and less painful. And now I'm off birth control pills. I'm trying to get pregnant, and I'm noticing more pain and more symptoms.
So the primary symptom is pain?
Pain with your menstrual cycle.
And is there cramping? Is that pain like a cramping? Or how would you describe that pain? Or how do patients describe it?
So it varies a lot, but it's always going to be the classical, hey, I've got pain as I lead up to my menstrual cycle, and then it's a lot worse during my actual cycle, and then it's going to get better. And then again, depending on where the endometriosis is, so if it's on the bladder, you're going to have pain with urination. If it's on the bowels, you can have pain with bowel movements. And then endometriosis loves to be behind the uterus, and so right in that posterior cul-de-sac area, so people will come in and say, I've got pain with intercourse. And that kind of tips you off. And when you do somebody's exam, sometimes you can notice that the uterus doesn't move as much. You can feel some nodularity down at the bottoms and things like that.
Interesting. You talk about being behind the uterus. As a physical therapist, one of the things we look for in women is back pain that's undefinable. And sometimes it's an endometriosis situation that refers pain to the back. Do you see back pain in women sometimes?
You do. You can see, whereas the classical thing is just that lower pelvic pain, you can have back pain, you can have chronic pain, and it becomes challenging because, endometriosis isn't something that you can see on an ultrasound. You might see an endometrium, a big blood-filled cyst on an ovary or things like that, but you don't see it on an ultrasound. There's not a blood test you can necessarily do where you're going to identify it, and the exam is going to be very non-focal. The only way you can actually find if somebody has endometriosis is laparoscopy, basically a surgery to go in and go look around for these little powder burn spots all over the place.
So as an OBGYN, when someone comes in, you basically are getting most of your information from a history. I mean, what their description of their pain, and then that leads you to kind of try to define what's going on.
Yeah, so it's going to be one of those things where you're going to go off the history, you're going to go off their symptoms, and you're going to try to manage this endometriosis medically. And then if you're doing things like putting people on birth control pills or things to suppress that endometriosis and it doesn't work, then you're going to be looking at surgical options to see if you can go prove they have endometriosis and treat it.
Our conversation with Dr. Heshmati continues right after this timeout on Komo.
It's a Northwest Lifestyle Weekend on Komo News. Now back to IRG's Health Talk.
We are back, and we're talking with Dr. Nariman Heshmati, Medical Director of Obstetrics at Providence Regional Medical Center in Everett, along with Shannon O'Kelly.
Dr. Heshmati, just to review, so endometriosis, you have these glands normally inside the uterus that basically are there to produce the lining of the uterus except implantation of an egg, if you will, right?
Yep, so you've got the glands inside the uterus that can respond to hormones, and that's going to be where pregnancy implants, things like that. And then when you have these glands outside the uterus and they're responding to those hormones, that's where you can get into trouble. And that's where one of the theories of endometriosis comes out. So the thought is that retrograde menstruation, or when you're on your cycle and people are going to be bleeding and they're noticing that maybe when they bleed backwards back through their fallopian tubes, that's where the endometriosis is actually, those glands are getting into the pelvis. Now the catch is, if you think about it again, 10% of reproductive age women have endometriosis. About 90% of people are going to have retrograde menstruation at some point in their life. So there's going to be a genetic factor of things. And sometimes you'll have families come in and somebody will say, hey, I'm having a lot of pain, and you think they have endometriosis, and their mom's in the room and goes, yeah, I had that. I had those same symptoms and those same problems.
So a little bit of a genetic component?
So there is a genetic component that's thought.
So my understanding is these glands are outside and doing their thing, but doing it in the wrong area.
Yep.
I mean, you don't get rid of them, do you? I mean, what's the prognosis?
So, endometriosis is a chronic, lifelong condition. And so it's one of those things where it can be a quality of life. It's going to cause pain. And the goal is medical management to try to suppress endometriosis. So we put people either on birth control pills and IUD, things like that. It's going to cause those glands to shrink. And you're trying to basically control their symptoms while minimizing how much surgical management you need to do. And then ultimately, if all else fails and someone's done having kids, then we do talk about things like hysterectomy and surgical management options.
If you have a severe case of endometriosis as a young woman, is it harder to get pregnant?
It is, because that endometriosis in there can cause a lot of scar tissue, can cause a lot of damage. The other thing is medical management of endometriosis. While it suppresses symptoms, it doesn't actually improve fertility rates. So there is more infertility that we see in there. But the one thing I always tell people is I have a ton of people who have endometriosis who are pregnant. So it doesn't mean you can't get pregnant. It does sometimes make it a little bit harder.
The medication that you use, you're basically trying to trick the body with medication to calm those glands outside of the uterus down to inhibit them from producing this lining or this bleeding.
Exactly. You're trying to shrink those glands. So, something as simple as birth control pills can do that. And then there's other things that are more aggressive. So there's a shot called Depo-Lupron that induces a medical menopause. Basically, it shuts down all the hormones, and it's kind of hard. You get hot flashes and things like that, but it's something that we sometimes aggressively use, and it's going to shrink those glands down and minimize those symptoms. Because again, we're trying to buy as much time as we can for people.
So our listeners, if someone's out there, what should be a classic symptom when, I should go see a physician to have this looked at?
The biggest thing is if you're having pelvic pain, especially around the time of your menstrual cycle. And what's important is even if you don't have endometriosis, if you're having significant pelvic pain, you probably should go in and have that checked out because there's a whole lot of other things that it could be.
Great information. Again, thank you for your time. I love this show because I learned so much, and you were great. Thank you.
No problem. Thanks for having me.
Endometriosis is the topic today, as we have discussed that with Dr. Nariman Heshmati, and I think that it's great for our listeners as they get to learn something new every week, but so do I. It's fascinating to hear about a lot of these topics that I never would have known about.
Well, there's so much knowledge and information out in the medical community now, and now, there's whole sectors of women's and men's health. We have certain situations based on our gender.
Yeah, that's for sure.
Yeah, right, yeah.
By the way, if you'd like to find out more, you can go to washingtonprovidence.org for more on that topic, and as well as more on Dr. Nariman Heshmati. Daryl Russell, president of the Russell Group, talking about the Breakfast Group. Not the Breakfast Club, the movie that was out in the 80s, but the Breakfast Group.
Molly Ringwald?
Yeah.
Yeah, okay, good. Yeah.
Judd Nelson. And,
you remember all that stuff. Look, you're the movie guy.
We'll find out what this Breakfast Group's all about coming up after this time out on Komo.